I'd like to welcome everybody to this virtual learning sponsored by Tactile Medical. The topic today is why vein specialists should care about Phlebolymphedema. We have a pretty exciting crew here. Steve Dean, Kathy Gibson, and Kush Desai. So we have a vascular surgeon, a vascular medicine specialist, and an interventional radiologist. We're going to try to make this topic as exciting as we can, which is always exciting. Steve always does a great job in making it exciting. So I'm sure we're going to be able to take care of that. Just some logistics. We're going to be answering questions during the talk, at the end of the talks, between talks, as these questions pop up. At the bottom of your screen, next to participants, there's a Q&A button. Please use that to enter your questions. We will have some polling during the talks to kind of go through questions that the faculty have put together, so you guys can vote on those. Anything else I'm forgetting, Steve? No? I don't think so. So I think there's a few polling questions that we wanted to start off with. And we'll go here on the first one. So the first question is, how much of your practice is dedicated to treating venous disease? All right, so we got share results. So we got 76% plus. I'm sorry, 39% of people have over 75% treating venous disease. Another 27%, 50 to 75. So we got more than half of their practice venous disease, and about 77% of the people on this call. Interesting. Okay. Our next question. So this is just for us to get a feeling of what our audience is here. For venous specialists, what are you predominantly focused on? Superficial only, deep only, or both? So I do both superficial and deep. I think, Kush, you're predominantly 100% deep. Kathy, both, right? All right, so we got 63% both superficial and deep, and only 4% isolated deep venous disease, and about a third of them, of the participants, superficial only. Okay. Our next question is, in patients with lymphedema, do you manage their disease, refer to a lymphedema clinic, or to a lymphedema physician specialist, like Steve?
No.
What percentage of your practice, Steve, is on lymphedema or leg swelling or?
Leg swelling, it's, I'd say 60 to 70% now.
Wow.
Yeah.
Okay. So we got over half the people, 54%, referred to a lymphedema clinic. 49% manage the patients themselves. All right. And I think this is the last, or actually two more questions. If you have addressed venous pathology and your patient is still symptomatic, what do you do? Keep them in stockings and send them home? Oops, sorry.
Yeah, I don't see anything there.
Send them to a lymphedema physician specialist for MLD therapy or prescribed pneumatic compression. So we have 60% of the audience prescribes a pump, 43% send them from MLD, 18% to a lymphedema physician specialist. All right. So only 9% just keep them in stockings. And we'll go with the last question here. After venous intervention, what percentage of your patients will have persistent swelling that you, in your experience? Less than 20%, 20 to 40, 40 to 60, 60 to 80. Kush, what would you say?
Well, I'm going to say that it depends on the pathology, but all comers.
No, in your practice.
No. I mean, if it's an acute DVT and I catch it, then it's zero. If they're compliant, but if it's a PTS patient, it's typically probably between 40 and 50%.
Kathy?
Have some residual. I mean, they're improved.
Yeah, they're improved.
They still have residual.
That's what I was going to say is somebody with swelling, it's very unusual to go from tons of swelling to none. The best, I tell patients my goal is improvement, not resolution. So I would say that 50% of my patients have significant improvement.
Right.
And 50% have a disappointing amount of improvement.
All right.
If it's just for swelling.
So 40% of the participants here have about a 20 to 40% of the patients have persistent swelling. So 20%, about 40 to 60% have persistent swelling. So it's kind of a recurring theme, that these patients obviously don't get better 100% of the time. So I think with that, I'm going to hand it over to Steve. And like I mentioned, any questions, just use the Q&A button at the bottom, and let's go.
Okay, thanks, Tony. So if I can get this to work here, share screen. So why you should care about Phlebolymphedema? From a disclosure standpoint, I am on the Scientific Advisory Board and Speakers Bureau for Tactile Medical. And before we start, I just want to go over a couple of questions, and we'll revisit this at the end of the lecture. Question number one, identify the true statement. That is, cancer therapy is the dominant cause of lower extremity lymphedema in the U.S. Number two, foot swelling is required in order to definitively diagnose Phlebolymphedema. Number three, toe swelling is required in order to diagnose Phlebolymphedema. Or number four, Phlebolymphedema predisposes patients to contact dermatitis. Which is the true statement? And I'm not going to give you the answer here yet. We'll revisit this at the end of the talk, but we can look at the polling numbers. I would say we'll give you 15 seconds and then move on.
Okay. So 63%. Go ahead.
May or may not be the right answer. We'll talk about that later. And let's go to this. I'll close this and we'll go to the second question. Question two, identify the subject with Phlebolymphedema. Patient panel number one, panel number two, panel number three, or panel number four.
Those are some exciting legs.
Just another day in the office, Dr. Gasparis. And apparently for a lot of people here too, we got a lot of vein specialists here. So we'll have fun dissecting that question. So I'm glad I presented that one. Okay. All right, well, let's move on and talk about why you should care about Phlebolymphedema. Well, reason number one is that understanding its pathophysiology provides insight into updated concepts in lymphatic failure. Now, back in 2010, Drs. Levick and Michael released the following article, landmark article, but released to really little fanfare. And it was entitled Microvascular Fluid Exchange in the Revised Starling Principle. So before we visit the revised Starling Principle, let's just look at the classic Starling Principle, by the way, derived in 1896. And in the classic Starling Principle, recall that from the precapillary arteriole, hydrostatic pressure drives filtration, leading to fluids and macromolecules, proteins, etc., accumulating in the interstitial space. And then if you go by the traditional Starling principle, this accumulated filtrate ultimately undergoes reabsorption in the postcapillary venule due to the resultant oncotic pressure gradient. Now, what Starling was not aware of back in 1896 was this endothelial glycocalyx, this slime layer that lined the blood capillary. And the issue with the glycocalyx is that the glycocalyx disrupts this oncotic pressure gradient. Because of the disruption, there really is no appreciable venous reabsorption of fluid within the postcapillary venule. Even everybody's taught that in medical school. So all this interstitial fluid, 100% of it essentially undergoes uptake in the lymphatics. So bottom line, the lymphatics, not the venules, are primarily responsible for maintaining tissue fluid balance and by absorbing interstitial fluid and proteins and returning the fluid into the circulation. So there's a revised Starling principle. And 4 years later, the international gurus of lymphedema, Doctors Mortimer and Roxon, released the following article entitled New Developments in Clinical Aspects of Lymphatic Disease. And the most succinct statement from this article was as follows, that all chronic edema indicates an inadequacy or failure of lymphatic drainage. So by extension, the edema associated with chronic venous insufficiency actually represents secondary lymphedema. And then from a CAB clinical classification standpoint, that's important in your practice, from the standpoint that any patient that has C3 disease or edema or greater, that is with skin changes, even ulcerations, by definition, that subset has chronic venous insufficiency. It's not just chronic venous disease. And all of those patients have associated secondary lymphedema or Phlebolymphedema. Now, this is interesting. Let's talk about the purist definition of what is lymphedema. So if you take a medical purist or perfectionist like Dr. Gibson, for instance, I mean, how would she probably define lymphedema? I suspect she would probably say it's the accumulation of protein-rich fluid in the interstitium which causes chronic inflammation and reactive fibrosis of the affected tissue. So that presents somewhat of a dilemma, I will say, if you have a patient with early C3 disease. I mean, could you truly say that those patients have protein-rich fluid with a chronically inflamed fibrotic environment? I don't know that that's necessarily the case. However, if you have a patient that has advanced C4b disease with lipodermatosclerosis, atrophy blanche scarring, corona phlebiectatica, or a stasis ulcer, there should be no equivocation in that standpoint at all. I mean, those patients clearly have a protein-rich fluid, a chronically inflamed reactive fibrotic environment. There just shouldn't be any equivocation about that. But back to that early C3, some people would say, well, that's really lymphatic failure. It may not be classic lymphedema at present. And again, that's up for debate. So what's the second reason that you should care about Phlebolymphedema? Well, it's clearly the most common cause of lower extremity lymphedema. And that's even though, if you look at, there's a plethora, if you will, of traditional and ostensibly up-to-date medical literature, which repeatedly states the following. That is, in the developed world, the majority of cases of lymphedema are secondary and due to malignancy or its treatment. Again, there's our up-to-date 2020 reference on that. And let's numerically break down the number of cases of secondary lower extremity lymphedema in the US and compare CVI versus cancer. Well, if you look at the European Society of Vascular Surgery consensus document 2015, they note that chronic venous insufficiency, again, that C3 or C6 disease, affects about 5% of Western population. So if you calculate the numbers, 325 million people in the United States with chronic venous insufficiency, or with 325 million patients, 5% of those 16 million have secondary lymphedema from CVI. And then you contrast that with the numbers, which are not great numbers, but yet Dr. Roxon's looked at this. And if you look at cancer-affiliated lower extremity lymphedema, it's about 1.5 to 2 million. So clearly, there's a discrepancy here in what's the most common cause. And in fact, chronic venous insufficiency, not cancer, was the most common cause of lower extremity lymphedema in these 4 studies. And 3 out of these 4 studies are quite contemporary. Let's look at the first one, a Mulick study in 2013, where 34% of the patients had chronic venous insufficiency, most common cause. Now, like I said, 3 of these 4 are contemporary references. 2019 Keast, this is from the Canadian Registry, 72% of their patients had chronic venous insufficiency. When you look at data from our institution at Ohio State, 440 patients, 42% of them had chronic venous insufficiency. And I suspect the number would have been much larger, with the exception of there was an obvious referral bias in our study, because these were patients who were evaluated at a cancer-affiliated physical therapy center. And then finally, data that's been submitted to, or for publication by Dr. Sapan Desai, looking at 1,100 patients, CVI was a dominant cause, 57%. So even though, again, all of these studies clearly showing chronic venous insufficiency is the dominant cause, I really do long for the day that this statement is abolished from the medical literature, that it's a malignancy and its treatment. I mean, because you can clearly see that the scales are weighted in favor of phlebolymphedema being the dominant cause, not cancer. I mean, phlebolymphedema is anywhere from 4 to 8 times more common to cause lower extremity lymphedema in the U.S. And I would ask you, especially if we have a population of primarily vein specialists here, what are you seeing in your practice? I mean, are you seeing post-lymph node dissection on a daily basis, or is it more phlebolymphedema? I suspect it's the latter. Phlebolymphedema is the most common cause of lower extremity lymphedema in Western countries. Now, number 3 reason why you should care about phlebolymphedema, it's associated with characteristic and diagnostic clinical manifestations. And here are 3 cases of clinically classic phlebolymphedema right out of a textbook. And they have the characteristic constellation of limb swelling, foot swelling, as well as stasis dermatitis and hyperpigmentation. And if you look at the case in the middle and to the right of the screen, you see that unusual tapering or exaggerated contouring of the mid and distal portions of the calf. It's consistent with chronic lipodermatosclerosis, or your inverted bowling pin leg. And we'll come back and talk about that in our test question that I gave you. You know, why you would feel the need to order lymphoscintigraphy in these patients that have obvious phlebolymphedema, I have no idea. I don't personally do it, but we can talk about lymphoscintigraphy in the discussion section. And this is an important point. Although I showed you 3 clinically classic cases of phlebolymphedema with foot swelling, keep in mind that foot swelling is not required to make a diagnosis of lower extremity lymphedema. I mean, here's a case, a patient has rather advanced venous lymphatic hypertension with a chronically inflamed fibroinflammatory environment, no foot swelling, but they clearly have associated lymphedema. And that's borne out on many radiologic studies that have looked at these patients. And then finally, our 4th reason that we'll talk about why you should care about phlebolymphedema, well, it's associated with very characteristic clinical ramifications. So why do these patients have these characteristic clinical ramifications? Well, it's all revolving around this underlying immunocompromised district. And that's an interesting term to use in the setting of phlebolymphedema. And it's simply, as opposed to saying a patient is immunocompromised from a systemic standpoint, your phlebolymphedema patient is immunocompromised from a sectorial or local standpoint. So table 2 outlines some examples of immunity-related disorders that can appear on a phlebolymphedema district. There's your big word for the day, Tony, phlebolymphedema district. Now, I suspect most of our participants here are familiar with the reduced immune response that you see in the setting of lymphedema that predisposes one to opportunistic infections such as recurrent skin infections. So this is why your patients with phlebolymphedema are typically calling you with recurrent cellulitis. And I think that's pretty well known. A little less well recognized is the fact that lymphedema predisposes one to recurrent and recalcitrant fungal infections. Recalcitrant tinea pedis. And it's interesting that in my fellowship, we were all taught that, well, the reason a patient with lymphedema has recalcitrant tinea pedis because they have this big swollen toes. It's a noxious, moist environment, and that's why they get tinea. And I suspect that's playing a role, but I would suggest to you it's equally important they're locally immunocompromised. And if I'd ask you to carefully look at your patients with long-standing lymphedema, look at their toenails. So many of these patients have onychomycosis as well, and this is all driven by this immunocompromised district. So we talked about the reduced immune response leading to opportunistic infections. A little less recognized is the fact that this predisposes patients to malignancy. So you can see this limb on the left has obvious clinical manifestations of phlebolymphedema and lymphatic veins. And they had this unusually refractory stasis ulcer. Been there for a couple of years. It's very friable. It was biopsied. This was squamous cell carcinoma. And the case right next to it is a verrucous carcinoma. Again, representing the effect of long-standing lymphedema with the immunocompromised district. And it's not just squamous cell. You can get a deadly lymphangiosarcoma with this purplish nodular appearance with a life expectancy of typically less than 2 years. Don't want to miss that. But again, driven by this immunocompromised district of Phlebolymphedema. And I think of all of the examples of immunity-related disorders that can appear on a Phlebolymphedema, I find this paradoxical, exaggerated immune response to be the most fascinating and definitely underappreciated. And this paradoxical, exaggerated immune response that occurs in Phlebolymphedema is what predisposes these patients to allergic contact dermatitis. So this is why you have a patient who will have a dried eczematous stasis dermatitis, and they treat it with a little Gold Bond over-the-counter eczema relief cream, and unfortunately it converts that dried eczematous stasis dermatitis to a weeping acute stasis dermatitis. They become topically hypersensitive to the associated chemicals in the cream. So, I can just see Dr. Gasparis saying, well, the problem is you're using an over-the-counter medication here. It's got these impurities in it. You need to use a prescription medication, and I suspect that will take care of that contact dermatitis. So he prescribes a TAC cream, if you will, and tells them to call me back in a week. It'll be better, but unfortunately, it's no better. Again, they're topically hypersensitized to the associated diluents, if you will, in the medication. And one little clinical tip is that patients are less topically hypersensitive to ointments than they are cream. So, Tony, you could have used a cream in that setting, I guess is what I'm trying to say. So let's wrap up what we just talked about, the 4 reasons you should care about Phlebolymphedema. Understanding its pathophysiology provides valuable insight into updated concepts into lymphatic failure, mainly that revised Starling principle. There is no appreciable post-capillary venular reabsorption of fluid. All this fluid is recirculating through the lymphatics. Number 2, it's clearly the most common cause of lower extreme lymphedema. Again, I long for the day where we quit seeing that it's cancer and associated therapy. Number 3, it's associated with characteristic and diagnostic clinical manifestations. And I would just say, don't forget you don't have to have associated foot or toe swelling to make the diagnosis. And at least 60% of you were aware of the associated clinical ramification of allergic contact dermatitis, which again, I find such a fascinating topic. But also don't forget about infection. And not just bacterial infections, fungal infections, and we talked about the virulent skin cancers that can complicate Phlebolymphedema as well. And I appreciate your attention. I assume you're attentive. I don't know. I can't see. But if you want to, we'll just go over these questions real fast and the correct answers. And everybody did pretty well on question 1.
So on question 1, how much of your practice? No, sorry.
What's that saying? Well, if you're, I don't know if you can still show the polling data, but yeah, I recall 60% of the people, it was 63. Roughly, did correctly identify that Phlebolymphedema predisposes patients to allergic contact dermatitis. And again, anybody that treats these patients on a regular basis gets that phone call that, I've got itching, I've got irritation after using prescription creams, non-prescription creams, et cetera. And this is all driven by lymphedema. So good job on that. And we talked about you don't necessarily need to have foot or toe swelling. And 21% said cancer was the dominant cause. Well, I'm glad we talked about this. So now I think the second one we'll have a little bit more fun with. Not that that wasn't fun.
This is the second question. Oh.
Yeah, we're getting okay. So identify the subject with Phlebolymphedema. Can you show the polling data on this?
This is the one. Patient 1, 21%. Patient 2, 23%. Patient 3, 22%. Patient 4, 34%.
Okay, well, I'm sure, Dr. Gasparis, you got this correct, but what a great example of the inverted bowling pin leg. I love showing this. These are got to be the most dramatic legs with chronic lipodermatosclerosis I think I've ever seen. And you can see, despite, obviously horrible Phlebolymphedema. They don't have much foot swelling. Now, as far as the case in number 1, that's primary elephantiasis lymphedema. The case in number 3 is classic lipedema, where you see the symmetrically fatty deposition with a very pronounced ankle cuff sign and no significant foot swelling. That's classic lipedema. And then finally in number 4, where I could understand if some of you may have chose that, but those purplish plaques and patches are not exactly typical of stasis, a little bit well circumscribed. And that's actually necrobosis lipoidica, which is a reported cause of secondary lymphedema. And I would say it also in the differential would be cutaneous sarcoid, looks just like that. It'd be tough to differentiate between the two. But,
the challenging thing in patient number 2 sometimes, this could be a patient with no venous disease and just obesity as a cause of what their legs look like.
Yeah, and what you obviously mean by that, no demonstrable obstruction or reflux, but clearly a lot going on from a venous hypertension standpoint.
Correct.
Yeah.
And number 3, one of the questions from the audience was, how do you manage a patient who presents with varicose veins and legs like patient number 3, where you can actually see she does have, or he does have some varicose veins?
Yeah, do you want to talk about this now or wait till the discussion period, or how you want to do this?
Let's talk about it now.
Okay, all right. Well, of course, I would defer to my interventional colleagues, including yourself, but I would just say I have such a large population of these patients. I would really, even with a grossly incompetent refluxing saphenous vein, I would temper the patient's expectations that if they think their legs are going to get considerably better, they're probably not. The most I see is sometimes some transient improvement in their swelling, their pain, but never dramatically affects the shape of the legs. May help the orthostatic edema a little bit, but again, I would always temper expectations because I see so many patients in my clinic that have had bilateral grade and small saphenous vein ablations in this exact same scenario, and they wonder why their legs are not appreciably better.
Kathy, how about you?
Yeah, I think that it's very, very important, again, to manage patient expectation with this. So you have to really hone in on what's bothering them. And the things that typically bother my patients with lipedema, they really dislike the way their legs look. You're not going to change that other than getting rid of the bumps, the varicose veins. But that cuffing at the ankle, it's not going to improve if you treat the veins. A lot of them have easy bruising and leg tenderness. That's not going to get better. If they've got symptoms that are referable specifically to their varicose veins and you can tease that out, or if they've had, for example, superficial thrombophlebitis, thrombosed branches that have been painful, then I think you can make them feel better. But again, you have to kind of divide what symptoms they have that are caused from varicose veins from the lipedema condition. Otherwise, they'll be very disappointed.
That's very well stated, Kathy, very well stated.
I mean, I guess the question is, which patient would you treat?
Would I treat? So if they came in and they said, look, these bumps on my leg, these little spots you see aren't what's bothering me, it's my ankles and the way my leg looks and this tenderness, then I would tell them that we should leave the varicose veins alone. Mm-hmm. If they said, look, I realize, or you explain to them their lipedema condition and that what I'm going to do is not going to help, and they say, despite all that, I either hate how this looks, these bumps, or these bumps specifically are tender or painful, or I've had a clot in here, then I tell them, then we can treat that part specifically.
Or if they have maybe unilateral disease with unilateral symptoms.
If they have unilateral varicose veins?
Yeah.
And they, I don't see unilateral lipedema, I don't think.
No, bilateral lipedema.
Oh.
And they have symptoms which you suspect are more venous in origin than.
Yeah, then I would recommend treatment. And that's an important point because this person has bilateral lipedema. And one thing I would ask them are, do both of your legs bother you equally? Yeah. And if they said, yes, both of my legs bother me equally in terms of my symptoms, then probably treating the venous disease may not make them feel better. If they said, no, my left leg is worse, and particularly in this area, or these are the symptoms I have, then you may give them relief. Or you may have somebody, you can't discount what you think their leg looks like and what would bother you with them cosmetically. So if someone came to me with this and I looked at those legs, I'd say, holy cow, why do you care about the bumps on your legs when your ankles look that way? That might be how I feel, but maybe that's not how they feel.
Yeah.
So, I've even offered some cosmetic vein treatment to patients like this, just really being careful to manage their expectations.
Steve, for that, just to follow up on a lipedema patient, do you send them early on for liposuction?
Tony, realistically, it's a distinct minority that ever undergo liposuction because it's typically not covered by insurance.
Mm-hmm.
So, I mean, in an ideal world, I would, but as a whole, it's not early on because they have to. Let's say if you even have a pie in the sky chance that insurance approves it, you've got to go through every single conservative modality to even have a chance that you're going to have any or have a chance of approval. So. Yeah, if it was a perfect world, I certainly would, but that's just not how it happens. And I would also point out here, just for the people that are not aware, that if you looked at Karen Herbst's data, overall, about 3 out of 4 patients with lipedema have significant varicose and spider veins, and it's just not uncommon. But I just still, it just boggles my mind the number of patients I see with lipedema that have had bilateral SSV, GSV ablations. I can't get over it, and they're not very happy with the results.
Kush, in somebody like patient number 2 who has, let's say, an iliac lesion, a Maythorn lesion, or has a superficial vein, problem, is it worth intervening on them?
That's a good question, and I take the same approach as Kathy, and we'll kind of display this whole construct in our cases. But I reiterate to them that look, the swelling is not going to get appreciably better with what we do. But in the case of an iliac vein lesion or a deep venous obstruction, if they have venous claudication symptoms that, they have baseline pain, or maybe they don't even have pain at baseline, but then they climb the stairs or they walk for a long period of time and they start getting focused pain in that extremity, I tell them that there is a decent chance that that's going to get better. And that's actually what's been my experience. But I'm very clear that the swelling probably is not going to get better.
How about patient 1, Steve? What would you offer this patient beside a pump?
Now, that is a patient that I am increasingly offering liposuction because I'm sure, as you obviously know, Tony, over, I'd say 70 to 75% of that limb volume represents fat. And the only way that's going to get better is liposuction. And I'm lucky that I'm at an institution that has an aggressive plastic surgeon that's quite knowledgeable of lymphedema, and he's done a couple of these cases, and they've just been so happy with the results. But that's, again, there's not many plastic surgeons that are doing it for lymphedema yet, at least not in the United States.
Yeah.
But that's the only other thing you're going to appreciably reduce the limb volume with is liposuction.
Now, Michael Ryborn is asking, or is commenting that he doesn't have compression pump in his area, and he's wanting to send his nurse off to learn how to do lymphedema massage. Is that something feasible for somebody that's in practice, and sending his nurse out to learn if there's no therapist in the area or no access to pumps?
Oh, it's definitely feasible. Yeah. And no doubt, somebody that's skilled in that therapy can certainly mobilize the fluid volume. But then you go back to, okay, well, what happens after the 2 months that they've worked on it? You still got to have some other modality to reduce the fluid, and that's where a pump will be handy.
All right. We got a few more questions, but let's move on. I think Kathy, you want to stop sharing there, Steve?
Oh, yeah. Okay.
And we'll move on to Kathy's presentation. The next 2 talks are basically some clinical cases, actually 2 clinical cases. Kathy is going to send us a patient with Phlebolymphedema with superficial disease, and then Kush is going to do the same thing with a patient with deep venous disease. Unmute yourself, Kathy.
Can you see my screen?
Yep. Okay.
All right, so I'm going to go over a case of a gentleman that I've been taking care of for many years. And this is he's currently 69 years old. And so I saw him first when he was in his mid 50s. And at that time, he had bleeding from his lateral calf. He had a cluster of varices laterally, not very impressive on physical examination, but like many of these, kind of a volcanic eruption when he did bleed that caused a big mess. He had no history of DVT. He was obese, BMI of 35, and has a history of sleep apnea. So at initial presentation, this is his left leg. He's got some skin changes in here. I don't know why this is laying on top of itself, but this double slide. But this is where he bled from. So this looks pretty innocuous, but anybody that takes care of these things know that they can be gushers when they go. And he's got, you know, some edema. You'll see on subsequent pictures this increases. And then this is his duplex ultrasound that he had. He's got GSV with reflux all the way from SFJ to ankle, 3 seconds. And the diameter is 8 millimeters. He's got varicose veins that aren't very visibly obvious, but were on ultrasound that cross his shin over into the area of the ulceration. He had no deep venous obstruction seen infrainguinally back in 2007. We weren't looking up in the pelvis very much. And he's got some deep venous reflux in his femoral vein. So I think we get to question 1.
Okay. So question number 1. There you go. What would you do as a main treatment modality in 2007 on this patient? There you go.
Okay.
So 49% endothermal ablation of the above knee and below knee segment.
Okay, so what did I do then? I did endothermal laser ablation of the left above and below knee GSV.
Everybody approves what you did.
Yeah, I treated the right GSV at a later time. He had a C5a disease. And what I didn't put in here, which is kind of interesting that I don't have photos of, but he did develop a squamous cell cancer later in his right leg that was excised and skin grafted. It was not as juicy as Steve Dean's picture, but nonetheless, he had that. I used foam sclerotherapy in the area where he had bleeding in those branches and placed him in compression. Okay, so other options that we would have now that we didn't have then, you could use glue and foam, Claravane and foam, or just use Varithena. So those would be all options we would have now.
What would you do today in this patient?
You know, it would depend on his insurance plan and what they covered. And usually if I've tended to, we've switched over to more using radio frequency than laser. That's just a matter of preference in our clinic. And I would feel probably my practice pattern would be I would do either venous seal and foam or radio frequency and foam would probably be what I would do. If the great saphenous vein was a little smaller, I would do Varithena, like if it was 6 millimeters.
Uh-huh.
Yeah. But I would, you know, go over pluses and minuses with them. I wouldn't have a strong preference for one or the other. The reason why I might, when I said not strong preference, let me back up, might go with a non-thermal is because of the below the knee component that you can treat kind of much lower without worry of nerve injury. So I might lean a little bit more towards that if his insurance covered it. Okay. Oh, one other option now, I said thermal to the knee and foam below, which I guess would have been an option in 2007 also. So he comes back in 2014, and the notable thing is how much more swollen he is now than he was in 2007, despite, you know, he's been wearing compression stockings. And you can see that I don't have a really good shot of the right leg, but his lipodermatosclerosis has increased. He had a small ulcer kind of where the arrow's pointing that healed with stronger compression and some wraps. He has not rebled, but his edema is getting worse. So we restudied him. His GSV on the left is still ablated. He's got a refluxing superficial branch that's above fascia, 6 millimeters, and goes all the way into the calf. On the left side, he has an incompetent perforator vein, and on the both medially and laterally. On the right side, his GSV is still ablated. His small saphenous vein is incompetent and does have some varicose vein branches going anteriorly. And in the near the area of where he had the ulcer, there is a incompetent perforating vein, and he also has a lateral perforating vein on that side. So this time we studied his iliac veins, and he's got normal phasicity and respiratory variation at the groin. He has no iliac compression on the right. You can see a visible decrease in diameter on the left, 8 millimeters compared to 12. And the velocity ratio is 1.2 with normal flow in the internal iliac veins.
So Kathy, go back one slide. So Steve, what does this look like to you as far as number 1, 2, and 3 for your differential?
Is this a trick question, Tony? It looks like Phlebolymphedema to me. I mean, what?
So what are some of the, I guess, characteristics that just by
Well, you can see there's some modest foot swelling, which is typically what you're going to see in Phlebolymphedema. You're not going to see a lot of foot swelling, just modest at best typically. And then you, as Kathy noted, there's some changes of lipodermatosclerosis and hyperpigmentation in the right leg, and there's some discoloration in the left leg as well. You got ectatic veins. It's interesting here that around the malleoli you have some extra fat, and yeah, that's a little unusual. You don't see a lot of that typically in a Phlebolymphedema population. There's always exceptions, though.
especially on the left side. I mean, you can't tell.
Yeah, it's a lateral malleolar fat pad sign, and lots of when you see that could connote that they may have some mild primary lymphatic genetic defect as well, which certainly can coexist with CVI. So.
And I didn't notice this when I made the slides, but in the middle picture, look at the nasty toenails.
Yep.
Oh, there you go. Case closed. Yeah.
There you go.
Yeah, and they've got white powder on them, so maybe he's putting something on them.
Yeah.
Okay, sorry about that.
No, that's perfect. Thanks. I like it. Okay, so do you want me to, I think we're now to, the next slide's another question, I think. So what do we do now?
You remember offhand to just summarize the ultrasound findings for them?
Okay, so he's got right side iliac looks normal. Left side, he's got visible decrease in diameter on B mode ultrasound. Velocity ratio, I think it was either 1.2 or 1.4 in the area of visible decrease. Normal flow in the internal iliac vein, so it's not retrograde. He's got on the right side, his SSV is incompetent, and he has incompetent perforators on both sides. On the right side, there is one near the area where his ulcer is healed that's 4 millimeters. And on the left side, his GSV is ablated, his SSV is normal, his saphofemoral junction is incompetent, and he's got a out of fascia branch that's 6 millimeters that goes down into the calf.
Okay. So if you guys remember all these findings, because I don't. Kush, would this be somebody that you would image proximally the second time they come back?
You have to wait till they answer the question. Otherwise it'll
Well, we got most of the people answered already.
all right, okay.
I mean, potentially, but you know, in a complex CBI patient like this, before I go and put a stent in, you want to make sure that you exhaust all the options from the superficial side first. That's my approach, at least.
And I'll show the results. There you go. 39% superficial and perforator ablation. Okay.
Okay. All right. So what I did laser ablation of his right SSV and of his pathologic perforator vein at the same time.
So what was his major issue
On the right side, he'd had an ulcer that I just got to heal with compression. So it had recently healed ulcer on the right side.
But he wasn't complaining of his swelling being a problem.
Yeah, no, I mean, he doesn't like his swelling and his legs ache. He's got, but the right side, the main issue was his ulcer. So the right side, the reason I told you I usually do radiofrequency ablation now, the reason I did not is because I don't like doing radiofrequency ablation on perforators because of the device is large. So I did treat the perforator near the area of the previously healed ulcer.
Yeah.
And I did foam in that area. I did not treat any of the other perforator veins in either leg. So I didn't treat the lateral one because it was not near the area of the ulcer. So I wouldn't call it pathologic, just refluxing. And I did not treat the left. Now on the left leg, I did some foam in the superficial varicosity. I think you could critique that and say maybe I should not have, because clearly that would not be very effective in treating his swelling. However, you could see from the other picture, he had some more of those little kind of spidery varicosities that had previously bled that have recurred. And even though he hadn't bled again, he was very concerned that he could because he travels internationally frequently. So I did treat that with some foam sclerotherapy. And we also increased the strength of his compression stockings.
Now, with him progressing his swelling despite treatment of his venous disease, 2007, anything else additional? Because obviously that especially on the left side, that superficial varicosity is not causing
His swelling, no.
like his swelling and or the skin damage that he has. He has a little bit of skin damage on the left.
Right.
Anything else? I mean, would you to try to control his swelling better other than?
Manual lymphatic drainage would be the next thing to do, I think, in this situation.
All right.
Yeah,
But
once that was done, I think it'd be a good candidate for a pneumatic pump as well.
Mhm. Right.
Yeah.
Right. Yep.
I mean, my only thing with MLD, and I send all my patients for it, is I don't know how it is in your place. It takes 3 months for them to get in.
So it waxes and wanes what we can do. So we had this golden period for a couple years where both of the hospitals I worked at had a bunch of physical therapists that were certified and did it. And then one of them just shut their program down. So now they're all funneled to the second hospital. So there is a waiting list.
Yeah. Right.
But we don't have any nurses in our practice don't do it. Our nurse practitioners or nurses, we refer for it. Okay. So this gentleman is a businessman, and he is a native of South Africa, and he travels to South Africa for business frequently. And I don't have as much verbiage here, but this is just 5 years after the last treatment that you just saw. So he came back from a trip from South Africa, and I think do I have on the next slide his clinical? Give me a second. Yeah. Okay. So he comes with this, and then on the next, we can toggle back and forth. You can see that his superficial veins that bled previously do look better. I don't have really good pictures of his feet, unfortunately, but he's gotten heavier since 2007. His BMI is now 40. He's got his left leg hurts now. He's swollen after an international flight. We check him. He has no DVT, no saphenous reflux, no superficial vein disease to treat, and he's got fever and chills. So what do you do now? And then I can tell you what I did.
Well, that's interesting, Kat. That presents if you wouldn't have said the fever and chills part, it presents a good differential, because are you dealing with a true cellulitis or a pseudo cellulitis from stasis?
Right.
I think you clued us a little bit there with the fever
sorry.
and chills.
Sorry.
Yeah.
And he has no COVID, right?
This was not COVID era. No, this was 2 years ago. So I think
Yeah.
I didn't put the year there. 2 years later, so 2016 or 20. I don't know. It was not now.
No,
I think what this shows is, progression, because he's gone. So I admitted him right from clinic because he was sick. And kind of the course of this gentleman now is he's had, I don't know if I put it there, but he's had recurrent bouts of cellulitis ever since. So he had IV antibiotics. He got better.
Has it swollen got better? Worse?
What's that?
Has it swollen swelling going?
No, not really. No, and now he sometimes gets cellulitis in that leg. He hasn't had to be admitted since then, and he sees an infectious disease doctor as well. And when he travels, carries, I forget which PO antibiotic, but if he's traveling and has any hint of it, he starts. But as we mentioned before, he tried manual lymphatic drainage because of his travel schedule, and he's pretty busy at work. It didn't fit his lifestyle. So he's somebody that I've now kind of working on getting insurance approval for a pump at home. So, which I think is going to be really helpful for him. So some issues though, again, is his travel schedule. He can't take that with him. So I'd be interested also to see what other panel members think about the progression of this gentleman's disease. And I also wanted to kind of put him in there that despite all my best efforts as a vein doctor, he hasn't had a recurrent ulceration since the second procedure, and he hasn't bled from his varicose veins since 2007. But there's been an onward progression of his symptoms despite all my best efforts.
Steve, what do you think?
While we now see what Kush says about looking at the deep system, I would just say from a supportive standpoint, when you've done all you can do, that's a perfect time to consider the use of pharmacotherapy. And I would consider the use of methoxyphylline or a venotonic such as diosnoplex, keeping in mind that both of those are recommended by the American Venous Forum Society for Vascular Surgery in their guidelines. I mean, that's the perfect scenario. What else can you do when you've done everything from a interventional standpoint? Obviously, weight loss is a huge issue in this guy as well. And then I would just defer to Dr. Desai and Gibson on the deep system.
The other thing I did for him is I did get him in for a sleep study, and he is now have a CPAP, which, because.
Great idea.
Yeah.
Really good idea.
Yeah. So he has tried pentoxyphylline. We did have him on pentoxyphylline when he had the ulcer. And I don't know whether he persisted in taking that, but that's really a good tip to revisit that. But I haven't had him on diosmin.
Kush, would you do an venogram IVUS to look at his iliacs, or?
Probably not. I mean, he's not suggesting that that venous stasis or deep downstream obstruction is the real cause of all of this stuff. He has no reversal flow in the iliac, internal iliac vein.
He had unilateral compression, at least on the ultrasound.
Yeah. For nivels, for me, I require a very high burden of proof before I treat it.
I mean, I think obviously skincare. I mean, you saw his nails as a source of his infections. His BMI obviously is a problem, so weight loss.
Yeah, we've been working on that for sure. The interesting thing is his wife is one of my profound lipedema patients, and it's so I take care of both of them at different problems.
I think definitely a pump for this patient. I mean, there is data suggesting that especially with the FlexiTouch reduction in the episodes of cellulitis and hospital admissions.
It's pretty dramatic reduction, Tony. 80% reduction in the Mandic study in 2015 in JAMA-Derm. I mean, that's an impressive figure.
Exactly.
Yeah.
And honestly, it's and I know you say the guy travels, but I mean, if he is going to take care of himself and avoid these episodes, it's not like they can't travel, or it's not easy to do it, but something to consider. It's just he needs to be involved. And the thing is with MLD is unless he learns how to do it on his own, there's no insurance that's going to cover 365 MLD therapy. So
yeah, and he's also approaching 70. So I think that probably retirement will be soon, and maybe he will be able to devote a little more self-care then. And that's sometimes we see too is having this chronic condition can take considerable time and effort for a patient to manage. So they really have to be self-invested.
Steve, given the progression of this patient over time, earlier, more aggressive management of his edema, other than treating his venous disease?
Yeah, but it's back to how are you going to do it other than a pump or MLD, or because if there's nothing else interventionally you can do, what else do you have to offer besides a pump, MLD, or if you thought his deep veins were involved in something, probably not. So skincare, and I'm sure Dr. Gibson actually looked between his toes for tinea pedis. It could be a nidus for that recurrent cellulitis. That's another thing I would do.
Well, you know, if I can't remember that I did, but next time he comes in, I will.
Yeah, you got. I'm telling you, in between that fourth and fifth digit, so many times you
Yeah,
pick
he
up
looks
tinea
like
there.
he could have it. He looks like
Yep,
he
yep.
definitely could have it.
And the immunocompromised district strikes again. So he clearly has venous hypertension.
All right. Very nice
Lymphatic.
case, Kathy. Thanks for sharing it. If you want to just unshare, and we'll move on to a deep case.
All right. All right, can everybody see this?
Yep.
Okay, so my name's Kush Desai. I'm going to be talking about a deep venous origin Phlebolymphedema in the last couple minutes of the seminar. So this is a, let me just close all this so I can see everything. 62-year-old female with history of motor vehicle accident in the 1980s with significant polytrauma. While she was hospitalized, she was diagnosed with a DVT and PE, and an IVC filter was placed. So at that time, I would have presumed it was the original Kimray Greenfield that was placed. Shortly after discharge, she developed severe left lower extremity swelling, and to a lesser extent, some right lower extremity swelling. And then now, fast forward to 2019, when I met her, she developed pain primarily in her left leg with extended, actually, I met her in 2018. Her main symptom, other than the swelling, is that she has pain, this venous claudication type symptom where whenever she exercises or climbs the stairs or something, her left leg is very achy and sore. She's undergone superficial ablation approximately 6 months prior to presenting to me. On exam, she has 3+ edema involving the entire left leg, varicosities above and below the knee, despite having truncal ablation. She does have mild to moderate LDS, no ulceration, no stigmata or prior ulceration. She does have 1 to 2+ edema on the right, and her Stemmers is positive on the left. I didn't take clinical pictures, so she was kind enough to share pictures from home with me, and this is what she looks like beforehand. And if you can hallucinate through the pixelated picture, it does kind of have that reverse bowling pin type appearance, and certainly it's accentuated when she's standing up. This is when she's
Hey,
in her
Kush,
bed.
what kind of injury? What's that scar from in the front?
This, she had a fracture.
Oh,
Distal, she had a compound fracture of her tibia
in the vehicle accident.
in the vehicle accident, yeah. But her whole leg is swollen.
Yeah.
But a good question, yeah, absolutely. So the differential diagnosis, secondary lymphedema related to polytrauma. This chronic CVI, deep venous insufficiency, post-thrombotic syndrome, and what is the extent of her occlusion? Is it all the way up to that filter? Is this Phlebolymphedema superimposed on CVI? We'll go on our first question, and Tony has the...
Yeah. There you go.
Okay, so what do we do next here? Do we do any further workup? Or do we do no further workup? This is lymphedema. Do we do no further workup? There's no benefit to any venous intervention in this patient. Do we evaluate the superficial venous system again because she has all these varicosities still? Or do we evaluate the deep lower extremity veins in the IVC? Keeping in mind that her main symptoms are that she has this swelling. She does have the varicosities that don't bother her too much, and she has pain with walking and exercise.
There you go. 83% evaluate deep lower extremities venous system.
A lot of people thinking like me. Okay, so
I did tell them that you only treat deep venous stuff. So that was kind of a giveaway.
not fair. So her duplex shows chronic post-thrombotic changes of left pop through the left common femoral veins. On the right, they're normal and compressible. We did a CT to look for proximal imaging. We just don't get great ultrasound images of the iliacs in my center, so we do a lot of CT venography. And I'm going to scroll through this for you. And if you look here, you see something that I see very commonly in patients with iliac obstruction. See this large collateral crossing the pubis from the saphenofemoral junction from the left to the right. And this is almost like the patient forming their own Palma procedure. It's a saphenous bypass that we've seen in a lot of these deep venous obstruction patients. And this is, I hypothesize, I published a small series of these patients where when they have unilateral obstruction, they often will develop a compensatory a compensatory claudication and edema type picture in the right leg as well, even though the right leg has never been affected by any sort of disease. And in fact, that's what we've seen in this patient as well. And as you go up higher, you can see that the iliac vein is calcified partially there. It's a little bit pixelated, I apologize. And then as we go up a little bit higher, she has a pretty clear compression right there. And then if we go up higher, IVC looks fine. Where's that filter? Well, it's not a filter. That's an Adams-DeWeese clip. She was told that she had a filter, but what had happened was it actually ligated the IVC or plicated the IVC utilizing this clip, which is no longer used before and no longer used today. So her IVC is compressed in that spot as well. And you can see it on a sagittal image how compressed it actually is, all the way up just below the renal veins. So we discussed that she has obviously very significant, not just some element of Phlebolymphedema and what her expectations should be, but we may be able to improve her claudication symptoms. And so we asked, is that a significant lifestyle limiting factor for you? And if it is, we can try and address that. So we did a venogram, and you don't need IVUS to make the diagnosis here. She has a left iliac vein long segment stenosis. You can see in multiple areas here. She has a compensatorily dilated right common iliac vein. That common iliac vein on the right is almost the size of her IVC, as you can see on this digital subtraction venogram. You see the median sacral vein right here, very common to see, and then ascending lumbar collaterals right here. So all very common findings that you see in iliac obstruction. And this is what her Adams-DeWeese clip looks like. You can see actually the teeth of the staple biting across the IVC. So, and it was very easy to cross, no problem. She has this collateral that's draining from an accessory renal vein immediately caudal to the clip, draining into the main renal vein immediately cranial to the clip here. So this is just to give you an idea of how significant this compression is. Before I didn't leave the stent like this. Just before I post-dilated it, you can see that she had a very significant compression here in the external iliac vein. And then we went on to post-dilate it, and this is what her completion venogram looks like here. So post-procedure, her left lower extremity swelling significantly improved for about a week. And then she returned to baseline 1 week later. Claudication symptoms slightly improved, but not a whole lot better. So what do we do next? I said that we might have to address this, which is this is a little bit more off the radar for most people, but and this is the second I've seen in my career. We decided to go after this, and we ballooned open basically all those teeth, and then in an off-label manner, we placed a tracheobronchial stent. So this is a Gianturco-Z stent. This is a 25 millimeter stent with an exceptional amount of radial force. It's actually meant for the bronchus, and we use it inside the great vessels actually somewhat commonly. We got it nice and open right there. And then we just reassessed the iliac vein while we were working from the neck. I sent a catheter down into the left iliac vein, and you can see our stent is nice and patent after the initial intervention. And her left lower extremity edema significantly improved after that procedure. And this is what it was. I mean, we can see a marked improvement in her edema. You see the dimpling here and all of this. I mean, it's pixelated, but I think most people would agree that it looks a lot better. And then it was worse again, back to baseline. About 2.5 weeks, I think, is what she had. But her claudication symptoms are completely gone. This is what she's like now. And as we scroll through the CT scan, you can see that we have the stent opening right here, and the clip is open.
Nice popping open the clip there, huh?
Yeah. And this is our iliac vein stent, and it's nice and patent. The collateral that's going across her pubis has diminished in size relative to the initial scan, so we can see that we've decompressed her right leg. Her right leg symptoms are completely gone now. And so she's undergoing manual lymphatic drainage therapy. She has regular appointments. She does have a home pump. She says it kind of works. She doesn't have a tactile pump, but she does have a pump at home right now. And she's noted some relief, but really the swelling is still there. So we're going to go to the final question. So what will we do next here? Just compression only? Oh, you know what? We did this one was out of order.
Yeah.
Well, what would actually? I'll just ask a question out loud. We don't have to answer this one live. What is there anything additional we can offer this patient to optimize her lymphedema care? We've addressed the deep venous obstruction. The superficial symptoms don't bother her. What can we do for her lymphedema symptoms?
Kath?
So I think that the pump's a good idea. Is she overweight?
No.
No. I think that the interesting thing to me in this case, skirting the question, is that her swelling got better and then worse again.
Yeah.
The claudication symptoms getting better and staying better, I understand, but I don't know why that happened. And I don't know whether you have any kind of thoughts, or my other thought would be, is your vena cava open enough? Did you IVUS it? Did you do pressure gradients? Does the DeWeese clip need to come off and then have it ballooned more? That, because the rest of it looked fine, but on the CT it looked like the IVC was still a bit narrowed. So
it is.
That's my question. Or so when you did the ballooning, did you have to go into each one of the teeth individually? And the hinge. So the other thing is, do you go in and release the hinge and or have a surgeon do that or something? But it would really depend on how much it was bothering her to make that worth it, because that's a bigger deal.
Right. So we talked about a surgeon removing the clip, and we did IVUS it. And actually, when you have the IVUS right at the clip, you lose all sonographic through transmission. You get no return echo. So you can't really tell. But there is no pressure gradient. We did do that. So assuming you have the linear series flow, there's no pressure gradient.
Got it. Yeah, I mean, I think that
the imaging, the contrast washing out nicely, the collaterals are gone on the CT. So I think, again, this is a patient who's got advanced Phlebolymphedema that, this lymphatic system, Steve's talk was beautiful, cannot compensate anymore. It's not functioning no matter what you do on the venous side. You may be able to reduce the venous hypertension, but whatever's left there, and don't forget, she also had a bad injury in that leg. I was asking about that incision. We see a lot of patients with knee surgeries and hip surgeries, and they end up with chronic swelling.
Right.
It's probably a combination of her advanced Phlebolymphedema, her previous trauma, that's giving her edema that's her lymphatic system alone, as is, cannot compensate. I don't know. What do you think, Steve?
Whatever you say. They asked me to answer all these questions. I've been going crazy and typing away. I'm sorry, but venous hypertension and lymphatic hypertension are bad. And that's what that's. What was it? I'm sorry. What were you asking about?
Steve, let me ask you a real quick. Do you have any pathophysiologic explanation, or at least conjecture, as to why her swelling improved, albeit for a week or 2 weeks after the opening of the IVC clip, and then returned back to baseline? Is it a redistribution of interstitial fluid, or do you have any thought on that? And I can bring
why
it up.
they got better, I don't know. But I would tend to agree with what if Tony had mentioned it. Probably their lymphatics were long burned out, and there was only so much you could do.
That could just be, after a procedure, maybe she was a little bit more, keeping her leg elevated or whatnot. A 1 week recovery, I wouldn't.
No.
But again, her major issue potentially is her venous claudication, which I'm sure has improved her quality of life.
It has.
By resolving that.
It has.
The question is, once they get that advanced, their lymphatic system is burnt out. You can't, any intervention you do, and this is really the purpose of this talk, of this session, is, patients with Phlebolymphedema, whether it's superficial disease or deep venous disease, there's a tipping point where any venous intervention may improve them and may not improve them. And from the Paul's experience and based on the literature, about half of the patients actually see any significant improvement, which means the other half there's not as far as the interventionalist point of view, there's not much to do other than medical therapy, which includes, weight loss, pharmacotherapy, MLD, and pump, intermittent compression, to try to improve that lymphatic drainage as much as you can to avoid infections and skin damage.
Hey, Tamara, I'm reading the questions here. Dr. Labropoulos weighed in and says the patient has significant remaining deep vein disease in the lower extremity.
Well, if they have deep reflux, right, from previous DVT, that is contributing too.
Yeah, the reflux is gone and the claudication symptoms are gone. I'm not sure how else I can optimize the deep system of the left leg. Then just assuming that somebody is going to be that angioplasty of the femoral segment, for example, is durable, and it really isn't. So he's right. I just don't know how to fix it permanently. I'm not going to extend my stents further down.
Did she use compression consistently after surgery?
Yep.
Right. This is an interesting question, Kush.
Yep.
Would you consider ligating coiling the collateral vein from the left to the right leg, which might have been causing her symptoms on the right side?
No, because that's now diminished and her right leg symptoms are gone. I've thought about it if it doesn't go away.
And how active of a person is she?
Very active. Very active. The problem with coiling that is that it's very superficial, and coils, it literally goes over the pubis, and coils there can erode through. You have to be very we've seen patients who have had fistulas, competitive outflows coiled, and have seen a coil pop out of their skin.
But again, these are the challenging patients that that we have. So let's see. Is she pretty compliant with her compression? I mean, obviously, changing her type of compression, because MLD or a pump will help during the time they're using it and controlling the swelling, but unless they're in some type of high compression, whether 40, 50 millimeter compression stockings, or if they can't accommodate that, using one of those Velcro devices can also help.
I'm sorry, 1 second. There's somebody that keeps on ringing me here. I'll be right back.
No problem. Kathy, what do you think?
No, I'd agree with everything you said. And also, there's been a few people that have commented, and I think that's absolutely true of calf muscle pump function and ankle mobility and making sure that the patient's walking and active and all of those things. Kush said that she was very active, but sometimes you have to query to a patient, what do they mean by that and what kind of activity they're doing? And their version of very active and your version of very active may be two different things.
Yeah. I mean, I find it hard if the extended DVT she had, that she doesn't have residual deep reflux.
Right. No, I'd agree. And
definitely going to have deep reflux. Looking at her leg, she definitely has, if you ask her to plantar flex and dorsiflex her ankle, she definitely has calf muscle dysfunction.
Yep, I'd agree.
So based on those two things and the fact that she has longstanding venous hypertension, there's not much more you're going to do. I don't think getting rid of that clip or anything else is going to help. Any other questions from the audience? We're getting down to the end of this session. Day and night compression with exercise and MLD. Steve, do you put patients in compression day and night?
I typically don't. I don't know. I'm not on a regular basis. Not that I haven't. It's just not on a regular basis now.
Mm-hmm.
I keep hearing about patients wearing this edema wear at nighttime and have had some really good results from a cutaneous standpoint, but I haven't been able to get it in our office to even try it. Why, do you?
No. One of the audience mentioned that.
Okay.
what is your routine for use of the pumps? I mean, I personally, again, because of my experience with, I mean, we send all our patients like this to MLD therapy. But by the time they get into a therapist, at least we have 3 or 4 centers around us. The closest, the quickest they can get in is usually 2 to 3 months. And in some places it takes 6 months. And I don't know how it is in the rest of the country, but this is what we have in New York. And because of that, I tend to put them earlier in a pump, just because I know even when they get into MLD therapy, unless they're doing it on their own, they're not going to be going there every day. Whereas, if they're not going to put a pump on, then that's their real problem. I kind of go with them, all the requirements and what the compliance, how important compliance is. And if I feel that they're willing and capable of using the pump, I will, I go pretty early in the use of it. As far as, there's some questions in there, as far as insurances don't approve, really the criteria are not that strict. I mean, especially for non-Medicare patients. With non-Medicare patients, they need to obviously go through use or trial of a simple pump before an advanced pump. But for private payers, at least in New York, and again, speaking from my own experience around here, I haven't had any major problems with coverage.
Yeah, I answered that, Tony. I was going to say, I said the same thing. As a whole, if you just document it, especially if they're not getting better over a 4-week period, they should.
Yeah.
I find them, they're usually fulfilled as far as prescriptions.
Yeah, and honestly, working closely with the your tactile rep in the area, they tend to be very helpful as far as making sure they instruct you or help you as far as what the requirements are for each insurance company if you need that to get over the hump. So that's not, in my experience, an issue. Yeah, somebody mentioned about Circade wraps, which again, those are the Velcro wraps, which are very helpful in patients who have limited mobility and putting on compression. So this is a tough group of patients, and this is obviously a topic that a lot of interest is out there because they're challenging patients to deal with. So, I mean, I think we pretty much covered most of the questions. There's a few here and there. We'll answer them as we're signing off here. But I want to thank everybody, Steve, Kathy, Kush.
Thank you.
Thank you.
Thanks everyone for watching us.
Yeah.
Yeah.
Thank you.
Any questions, you guys can reach out directly to Tactile. And I'm sure they can get you our contacts if you have any specific questions for us. In general, I think takeaway message from this is, Phlebolymphedema is well recognized nowadays, especially with so many physicians in the venous space and experiencing these patients where they do have difficulty getting rid of their swelling after you treat their venous disease. So, early management of their edema, both with treatment of their venous disease to prevent burnout of the lymphatics is important, but also aggressive management of their edema to prevent skin damage and recurrent cellulitis is important. So I want to thank everybody and looking forward to everybody joining us in the next webinar, which is coming up on June 11th. Steve Dean, again, is going to be part of that group, I think, right?
I think so, yeah.
Steve, who else is with us?
Karen Herbst and Tom Wright.
I know we had a few questions on lipedema on this session, but if you want to learn more about myth busting and case controversies, join us on June 11th.
Yeah, this should be really good. We're just finding more and more interest in lipedema. I find it fascinating, which is great and rewarding. And so, yeah, hope you can join us.
All right, everybody. Have a good night.
Thank you.
Hey, thanks, everybody.